So just as a way of starting the recording and saying a little bit more, so this is the CFHA, Collaborative Family Healthcare Association, Psychiatry Special Interest Group. And we are a relatively new group, which I'm co-chairing with Mark Williams from the Mayo Clinic. And I know that there have been psychiatrists and psychiatric nurse practitioners involved in CFHA off and on over the years. And we're trying to increase our presence in terms of learning from our colleagues that are not psychiatrists, not prescribing, but also to provide what they need in terms of getting input from psychiatrists and prescribers and what all we can do. So usually the special interest groups for CFHA are members only type of groups, and but for the next year we're going to continue to have meetings that are open to anyone. This is probably the third one that we've had, and at this moment we don't have a standing meeting time. What we've done is to try, as speakers come along and of interest, we've scheduled it at the speakers convenience, but they've been around the noon time, and so we may need to move toward having a standing either, but we don't know, would it be helpful to have it monthly, bi-monthly, quarterly meeting? We've certainly had some good conversations of people who have joined on this group. We had Dr. William Beecroft give a presentation of the program that they're doing in the Michigan Blue Cross Blue Shield co-care program. And at the moment, I'm not remembering who our previous speaker was, but so we're just trying to get this going. And I appreciate Dr. Pomerantz being willing to speak up for us in this meeting. And there may be anywhere from, there's 9 of us on, but we may end up, and in the past, we've had as many as 30 or 40, depending on the subject. But since we're a small group at the moment, I think it is a great idea for us just to introduce ourselves. If you want to put your name and organization and your role in the chat box, that can be helpful also. And so we'll just take a few minutes for a quick introduction of those of us that are here. I'm Patty Gibson, and I'm a psychiatrist in Little Rock, Arkansas, and I have a couple of different roles. One is with a nonprofit organization called Arkansas Behavioral Health Integration Network. We're just forming, and we grew out of a small CPC Plus committee with our shareholders and primary care clinics in Arkansas. I came to love integrated behavioral health at the VA when they told me to go to the primary care clinic in 2009, and I had no clue what to do. And the next year or so, I met Andy and said, what do I do here? And have been learning since then. And I love doing integrated behavioral health. So I also have a role in our Baptist hospital system in Little Rock and in a newly forming psychiatry residency in Little Rock. So glad to be here and to be meeting and connecting with people. So if y'all want to take a minute, Andy will save you till the end. And
good idea.
I want to just take a minute and introduce yourself.
I can be pretty quick.
Go ahead,
yeah,
Jackie.
I'm the membership and conference manager with CFHA. So a lot of people hear from me, but if you are not currently, even on our mailing list, if you post your email address in the chat, I can add you to our mailing list. So you'll get information about our conference and other CFHA information. I will send you information by membership, but you do not need to become a member to be part of this SIG right now. So.
Thank you, Jackie.
I just put my a brief statement about myself in the chat box. Child and adolescent psychiatrist, and 15 years ago I founded a national organization dedicated to getting the latest science into the hands of healthcare providers. So everything from therapy to training primary care and how to address manage mental health problems, etc.
Thanks, Peter.
Hi, my name is Justin Hunt. I'm the medical director for behavioral health at a company called Oak Street Health, which has primary care clinics across the country, and we're implementing the formal collaborative care model across those clinics with a virtual psychiatry model, and having BHSs, as we call them, behavioral health specialists and social workers in all the clinics. And gosh, we're up to like 15 states now and about 80 clinics. So it's exciting. But previous life and academia in the VA, I was the chief of mental health here at the Fayetteville, Arkansas VA. So I'm two in Arkansas, but up in the Northwest corner. But really great to be here.
Ken, you want to jump in there?
Okay, all the guys are going first. Well, you went first, Patty. So I'm Ken Thompson. I'm a psychiatrist here in Pittsburgh, Pennsylvania. I work in a federally qualified health center and in a community mental health center and an HIV clinic and a variety of sort of settings around the city. Previously, I was, among other things, I was the medical director for the Center for Mental Health Services in SAMHSA. And we were talking before, I was talking with Andy before meeting him years ago at a conference that I helped organize. I was the, in addition to a guy named Don Weaver, who was from HRSA, he and I from SAMHSA and myself from SAMHSA organized a series of meetings on integrating primary health services and behavioral health services a long time ago. And I don't think that we can claim this, but I might, actually really saw that just take off like wildfire. It was really an incredible kind of thing that we were able to sort of propagate. And whether or not we actually propagated or it was just the right moment, I don't know, but it did take off. I'm a proponent of whole person healthcare, and I actually think I'm going to go one step further than you did, Andy, earlier. I don't think this is just about mental health care. I think this is actually about the redesign of American healthcare and the development of whole person primary health services that are tied to community and resources and a fundamental focus on well-being. And it's a very, very broad approach, but it's essentially redesigning the American health service, health system to the degree we have a system. So that's what I'm about.
Thank you.
That's awesome. I'll jump in. I had my video off because I am also eating lunch. Mary Langley, I'm also a VA person. You can see my really non-existent background, which is a blank wall. I'm sitting in one of the 4 community-based outpatient mental health clinics that I run. My title is section chief for CBOC Mental Health. And this community that I'm in today has a good representation of Oak Street Health, which I'd love to learn more about. I'm sort of an integrated care wannabe. I was the women's health psychiatrist for many years, so I was doing integrated care as part of my daily routine. And so I've been following Dr. Pomerantz and his career and his writings, and I respect that very much. And so I'm kind of self-taught in primary care mental health integration, as we call it in the VA, and do everything I can to try to further that model in my own work in my own VA, which is in Chicago. Thank you, Patty, for organizing this. It's really great.
Thanks, Mary. Glad you're here. Lisa, you've been hanging out there a minute.
Hello, I'm Lisa Crystal. I work at Lawndale Christian Health Center in Chicago, which is an FQHC. And I've been there a couple years, started an integrated care model. We've had a really strong behavioral health department there that's been very integrated and strongly connected with CFHA. And so I was able to kind of come into that. I love primary care and was planning to do it for a while. So it's been exciting to be able to bring psychiatry into there. It's definitely been a challenge, as a lot of our folks are not in kind of the classic collaborative care type model with just depression, but it's like a lot of folks who just can't follow all the rules for traditional psychiatry practice, and the wait list is 4 months and they're acutely psychotic. So there's, yeah, it's been an exciting place to be, but a lot of challenges along the way.
Thank you. Glad you're here. Jake and Jessica, we were just going around introducing ourselves. Since we have a small group, feel free to jump in there and introduce yourself if you'd like, but you're also free to hang out and. Hey, Jessica.
I am Jessica Booth. I am the clinical director at Cognitive Psychiatry of Chapel Hill in North Carolina. And I am here because we are in the process of trying to create some integrated care with PCPs in our area, and in North Carolina that doesn't really exist right now. And so we're sort of pioneering that in the area. So we're looking to see how we can get some benefit from our psychiatrists as we start this process.
Great, thanks. Hey, Jake.
Hi, my name's Jake. She's my supervisor, Jessica is, and I'm just here to learn. I'm an intern counseling program. So yeah, just here to listen.
Awesome. We are glad that you're here. Diana, if you want to jump in real quick, you're welcome to. If you'd rather not speak up, that's fine as well.
Hi, can you hear me?
Yes.
Okay, great. I have a lot of trouble with my computer audio, but hi. I just jumped on, so I missed the intro, but I'm a CFHA member. I'm interested in understanding a little bit about this group.
We're not hearing you very well.
Yeah, that happens.
Okay.
I'll type it in the chat.
Okay. Thank you. Well, I'll go ahead and introduce Andy. He is the National Mental Health Director for Integrated Services for the VA since 2011. And he was a primary care physician in Vermont, Central Vermont, for 12 years before he started his training in psychiatry. So having worked in his whole career in primary care and then in mental health. And sorry, Andy, I'm botching this introduction, but also
okay, you can stop. VA. Yeah, you can stop. That's okay. I mean, it's all irrelevant anyway. I mean, it's a great opportunity. I'm currently the kind of apropos of what Ken talking about healthcare. When I took this VA central office as the director for integrated care, I always said my job, the outcome of my work is to eliminate the need for my job. And at this point, as of a couple of years ago, the job has changed dramatically. And it's really about healthcare, but it's prevention. It's about how mental health fits into healthcare in a seamless way, how it becomes healthcare. The last couple of years, I've devoted a lot of energy to implementing a program that puts mental health peer specialists in integrated care working in PACT. We have 30 sites across the country. You folks in Chapel Hill, been getting some guidelines. I'm consulting a lot with Ed Fisher, who's in your shop, runs, International Peers for Progress, and he's provided some valuable help. But it's been a new thing. It's kind of like taking the convincing people that you need to do something different to practice, mental health and primary care. Peer specialists know nothing outside of what they've been trained for. So it's been training them, helping primary care develop roles for them, and the program's pretty successful. My task now, and I have 6 months to do it because I'm leaving the VA in 6 months after a long time. Task now is to lead the implementation of the whole health approach, patient-centered care in primary care and mental health, which is also a very tough sell, particularly with mental health providers who have been, working for decades trying to get respectability by getting more and more evidence-based, more and more scientific, and leaving all of the soft stuff behind. So the task there is to bring about change in attitudes. My work has always been about persuasion and motivational interviewing. So I've got 6 months time. My role is going to be to launch that as well as mentor my successor in the integrated services position. But the position now is really about, healthcare and mental health care. Now I did prepare a couple of slides. Some of these have gotten me almost thrown out of some psychiatrist meetings, but I'm going to put them up anyway. There's some slides that I first put up for a talk with the Wisconsin Psychiatric Association years ago when they wanted me to talk about the psychiatrist shortage. And so I said, well, I know nothing about that, but it was a twofer because they were already paying for me to come talk about integrated care. So I looked into it and came up with the conclusion that maybe we don't have a shortage of psychiatrists. So I've been kind of pounding on that theme for a long time. So I am going to go ahead and share the screen and see if it works. Hopefully I'll share the right thing. And when I do this, I lose some control. So yes, I have lost my cursor again, but I'm just going to click through this and I should get it back when I'm done. So the question always comes up, do they need us? In VA, about a third of the programs, and there's integrated care is in every VA facility in the country, and about another 100, 150 community-based outpatient clinics. Initially, it was just the larger community-based clinics. We have recently extended that requirement to all clinics. So it gets me to the first slide about, so what is the problem? Is hearing about I can't even see the whole slide because I can't move my cursor, but you can. What we always hear is there's a shortage of psychiatrists. They're just not enough to meet the growing demand. I like to look at it a little bit differently and think about it. Is it really that there just is not enough access to assessment and treatment to meet that demand, as opposed to meeting, just hiring more psychiatrists? And we all know what we think about people who keep doing the same thing over and over again, expecting different results. And I think we do that whenever we throw more money at a problem without any change. This is a quote from a paper. Interestingly enough, when this was a Green Journal publication, right about the time I was finishing my retraining as a psychiatrist. And I read this article and said, well, maybe they aren't going to need me. And really what the statement suggests, and again, this was made in 1987, so a lot of time has gone by since then, that really with the shift to basically team-based care, psychiatry is going to be used in a different role. And maybe we don't need as many of us, and maybe there are going to be too many of us. And that maybe what we need are psychiatrists who are trained a little bit better. Dissecting that prediction, I think we can assume. Basically, the prediction did not come true. There has been a big shift to team-based care. It's still growing. More and more FQHCs have come along. The community health centers have grown. Some have merged with community mental health centers. But basically, we're still saying we need more psychiatrists. Otherwise, we can't do our work. We also have a lot more people who, as the article predicted, we have an awful lot more people and other types of providers, both mid-level providers, as well as I said, peer specialists. It's amazing what a mental health peer specialist can do. So here's what gets me to think a little bit more about the problem. We may be one of the few guilds around that is arguing that not only do you need more of us, but you need to pay us more. That's not an argument that sells well in healthcare these days. And so we really need to demonstrate that you're getting a good product for what we're costing you. There's a lot of hope, and still have hope, that the Accountable Care Act, which is just the first tiny step towards changing healthcare, that one of its principles was we need to find ways to reward the value We do not just services, not just keep paying for more services. Then comes the question, I just don't think we'll ever have enough money. I can't remember what percentage of the GDP we are now, but we can't afford to do what we want. So could we make do with the number of psychiatrists we have now instead of making more and paying them twice as much at least as most mid-level providers doing similar work? Or can we do something? What can we do with what we have? So it leads to the question, and believe me, I've had these discussions. As I say, I haven't exactly been thrown out of meetings, but not invited back to some meetings where I've had this discussion. The APA's VA Psychiatrist Caucus was one I didn't get invited to after I gave this discussion the last time. So here are some of the things that we do. I think we play a lot when I talk to psychiatrists. What I'm always hearing, we're the best trained of anybody. But then when you ask what do they want, I'll often say, well, I want to be paid to do psychotherapy just like anybody else. It doesn't matter that it costs twice as much. I was certainly trained in psychotherapy, and as a psychiatrist, I do psychotherapy, but it's not an hour. There's no such thing as a med check. I'm sure VA people have heard me say that before. MedCheck is a psychotherapeutic encounter, and you build on the skills you've learned in psychotherapy. But aren't many people going to pay us to run a manualized therapy on anybody or do the supportive therapy? I think we have a key role in the collaborative care model. The VA program in integrated care is a combination of think of it as an enhanced behavioral health consultant, as we have a number of short-term therapies that we've piloted and tested in VA and are spreading, combined with the collaborative care model, which we all know and love. You also often hear the thing about, well, a doctor's only going to listen to another doctor. They're not going to listen to anybody else. And maybe that was true many years ago, but I don't think it's true anymore, at least not in my experience. So I've been to countless number of VA medical centers to help them get their program going. I've been an ongoing consultant, both inside and outside the VA. Worked on the Robert Wood Johnson Depression in Primary Care project many years ago before I was in my current job, consulting with the FQHCs in Vermont and getting to know, what they were up against as they tried to do what they thought they wanted to do. And at the time, most, with only one or two exceptions, were basically just trying to provide traditional psychiatric care in a primary care practice. And like I discovered when I tried that in my own practice in the early 70s, it didn't work. I had somebody from the community mental health center 25 miles away come over once a week. Within a couple of weeks, his caseload was filled with patients who he found needed a lot of therapy. And so after a few weeks, there was no room to see anybody, and patients would come to me. You sent them to me to help with, despondent and discouraged over not finding a job, and he's talking about my mother. So those were all the early efforts at integrating, and many programs still, when they're going to integrate care, they start by just moving some mental health providers into primary care and start doing it. So the question becomes for me and others, growing number of others, what is it that psychiatrists bring to integrated care, to healthcare in general, to primary care, to patients, to society, to the population, that a team made up of various providers, including, licensed social workers, nurses, psychologists, advanced practice nurses, PAs, and clinical pharmacists are not able to do. And I think that is the question. And I would love to hear, good, now it's going to give me my control back, I think. I'd like to stop sharing. Good, I think I've stopped sharing. So what I'd be interested in hearing from you guys is, what is our unique role? What do we do that can't be done by a nurse practitioner? I mean, in VA, nurse practitioners have full practice authority. some people need supervision, some of the providers, but with only about a third of the programs in our system deploying psychiatrists into primary care, and I've talked with most of those programs, what is it that we offer that is our reason for being and can help keep our profession alive? So I will stop with that and toss that open for either argument with things I've been talking about, or just thoughts about what is our, what's our elevator speech about what we do.
I'll jump in. From my point of view, we do a little bit of all of those things, and we do it with confidence and expertise, such that all of those people will tend to come to a psychiatrist to consult when they're not so sure that they're doing it all well enough.
Mm-hmm. So either the other provider is uncertain and wants to consult with someone, or maybe the problem is more complex than that provider is able to handle.
Yeah, I'm always struck that a great nurse practitioner or a great primary care clinician or PA, it's amazing what they can do. And it kind of, to my mind, overlaps about 85 or 90% with what psychiatrists generally do. But psychiatrists, as we've become increasingly less available, opting out of insurance, it's really a broken system, and it's hard to argue psychiatrists are necessary, except kind of at maybe the level that was just said, a consultation for difficult cases.
I can remember giving a presentation at Grand Rounds at a school I won't mention, where one of the psychiatrists in the audience said, well, we really need a lot of easy cases. It's hard to do the stuff that you're telling us we ought to be doing. We need easy cases too. And others have said, I've heard others in some facilities, hey, it's not fair. Integrated care gets all the easy cases and we have to get the hard ones. That's kind of what I get from people. And yeah, sure. Back when I was not a virtual employee and I was in the office every day in the clinic, I used to like making copies, standing by the copier, listening to the rhythmic kind of meditative thing that it does. But I don't think they liked paying me a lot of money to do that. So yeah, I mean, I agree with you, Peter. I mean, I think that's one of the key roles we have. When I many years ago, as clinical pharmacists have taken a very prominent role, particularly in the VA and some other organized system, to help make up the gap in expert prescription writing. More and more clinical pharmacists now have a 1-year psychiatry residency, in fact. And I was listening to all the things I do. I said, well, what do you need me for? What do you need? Is there a role for psychiatrists? Some of them weren't sure, but the ones who knew that they'd better humor me said, oh yes, for the difficult cases, the ones that we can't manage on our own, the really complex ones. They're not, clinical pharmacists can't make a diagnosis, which is one of their, they're limited in doing that. So they certainly need us to confirm a diagnostic impression.
I think in my work, these are a lot of the questions I'm asking. Is I'm working in a large team and I'm the only, well, now we have 2 psychiatrists, but trying to focus on which are the ones that do need a psychiatrist. We have great behavioral health providers, some of whom can do a lot with diagnosis, but I find I'm taking more consultations on the trickier ones, like, do they have bipolar? Do they have complex trauma? Where does substance use go in there? And some of that kind of like bigger picture stuff where I've got more kind of biopsychosocial overround view. And then I've also been seeing a lot of folks with psychosis, especially the younger ones, to have more specific conversations with them about treatment from the perspective of a psychiatrist who can give like I think a stronger argument about treatment, or like have that kind of background knowledge about how you can talk with someone well about their mental health when they don't have much insight.
So sometimes playing the role of the real expert on the team from the patient's perspective, you know, you're the one who can provide that kind of information that others might not be able to provide.
Mm-hmm.
You know, in our work, we have like kind of a highly comorbid Medicare, pretty vulnerable population. And we currently have 2 psychiatrists and then 6 psych nurse practitioners in addition to the 2 psychiatrists. And one thing I've definitely observed is this, among the psychiatrists, a better understanding of kind of the psychosomatic med-psych side of things. So really understanding those comorbid medical diagnoses and how they play in to the psychiatric suffering and also into our ultimate prescribing as well. I think we do have a important set of skills there that I think we need to hone to make ourselves more relevant.
I'm going to throw in a couple things. One is that in whole person healthcare, in whole person primary health services, which is the term I use rather than collaborative care or you know, integrated care, because I actually think that it's beyond integration. It's actually fusion that we've moved to, or we're trying to move to. So we're looking at a whole person. And one of the changes I think that's occurred, Andy, in the 30 years since Boris et al. Wrote that article, is that it's really become clear that psychiatric challenges are sort of the next wave of epidemiological challenge to the society. It's not a small element or a vestigial element of medical care. It's actually highly, highly central. And if you talk to anybody who's doing primary health services, they will tell you that it's a key component of almost all the work that they do. So in redesigning whole person primary health services, what that implies to me is that you have primary health services that are capable of taking care of the vast majority of folks before they have to get to specialty care. And the higher level capacity you have in your primary health services, the more folks you can keep from going to your secondary levels of care, which is why I think it's helpful to have psychiatrists in some of the roles that we've talked about, both around patients, in particular patients, but also to start thinking population health-wise systematically, and how to develop what primary health services actually look like beyond the concept we have right now of going in and seeing a doctor in an office. That is actually a limitation on our view of primary health services. And we need to be thinking more about the kind of things that we're doing to support people's health and mental health and well-being in communities by working at a broader level than the individual clinician. So that'll just take it. And I'll give an example of that. I'm currently now working on bringing a form of large group dialogic therapy that was invented in Brazil by a guy named Alberto Barreto. It's called integrative community therapy. It's been around for quite some time. It's all over the world except in English-speaking countries, and particularly North America. So we are bringing this in, and it's in Brazil, for example. It is an appendage to every single primary health service that there is access to integrative community therapy group that people, if you find that they're having struggles or challenges, that you refer people into, and they develop the term of art is solidarity care, that it is beyond individual clinical care to actually getting a community to be in connection and emotional resonance with each other, and has been really quite profound in what it's been able to do in Brazil. So I would suggest that psychiatry is about inventing the future of whole person primary health services that attend fully to the emotional challenges and the psychiatric challenges that a population experiences. And I'll stop there.
Yeah, I know, don't stop. Well, stop, because I want to say something too. I'm often thinking about how much we are trying these movements, whether it's integrated care, whole health, whole person care, are all trying to bring us back thousands of years to the beginning of humans, who basically treated the community, and saw the individual patient was just a symptom of the community or the, or the family. And it's powerful. And it was before we had anything else, we had that. They once called me a shaman after I started talking like that. You're nothing but a shaman. So that's fine. I wouldn't mind that. Ken, are you aware of any systems where it's really highly developed in this country? Where you could really, boy, there's a system that's really got this whole person thing going.
I mean, I can look at the practice that we have in the clinic, in the health center I work in, and as far as I know, we're as close as we come. I mean, we have Cherokee does a significant amount of this, although, the challenge is, and I think this is for me is, and this is the work of psychiatry, is to figure out in each setting within that primary health setting, what is possible to do in that primary health setting versus what has to go on to some other higher level of care, community-based care, and what are the relationships between those primary health services and those secondary services. That's a huge challenge because there isn't really any clear guidance in thinking about that I'm aware of. People sort of operate within the immediate rules that they have, but we haven't really tackled that issue. Because I don't think within psychiatry, people understand that if we don't develop really high level primary health services, we're never going to have good community mental health. It's a non sequitur to think you have good community mental health and crappy primary health services. And we have kind of crappy primary health services right now as a system. I don't know if that answers your question. I guess the answer is
yeah, it does. I mean, I'm on the search. There are a couple of places in the VA where they have kind of taken the whole health approach and begun. That starts with meeting with a peer who may or may not have may not be a mental health peer specialist, but a whole health peer, whole health coach, who does the personalized health planning, they call it personalized health inventory, which is an analysis of 9 different spheres, food and drink, rest and relaxation, spirituality, and healthcare is just a tiny little part of that pie. And they start by doing that. And saying, what do we need? Well, maybe we need to, help you get your mortgage paid, or, maybe we need to help you with your spouse, or maybe, maybe you've lost your spiritual center, something, to kind of guide rather than you coming into the system to here's your but kind of start with that. And there are a few that have taken that on. We have the 18 flagship sites, which were the first, got a lot of money to implement whole health approach, but even that they still not. It's been a couple of years, and expanding another 37 sites are adding it now. And very often, often the resistance is within mental health. Sometimes it's within primary care. We, like others, we have this thing called billable encounter that haunts us. We measure workload, we measure RVUs. Another part of my job has always been to talk with local service chiefs about why the usual RVU formulas don't work for this kind of work, why we need to abandon those, but they're used as a way to understand who's doing what, but they don't even get us there. One of the things we're trying to do is get some of these sites exempted from those guidelines. But the VA says it's not a fee-for-service system, but it is. I mean, it is capitated, but it's based, the more services you provide, the more money you're going to get as soon as you bump a patient up into the next category of complexity. If you see him a serious mental illness and you see him 30 times, 29, you don't. So that's I know that's a barrier everywhere, and we're not immune from that. It's tough. As well as some of our performance measures. You know, VA, you know, like many who have performed quality measures, they've kind of been perverted in many ways. They're not as much about improvement as in about assessing how well you're doing and how much you should get paid and so on. But there's take a performance measure such as somebody has a diagnosis of post-traumatic stress disorder, has been seen twice in mental health. They're required to have 6 sessions of cognitive processing therapy. You know, well, how do you suppose whole health approach points you in a different direction? Well, then you're not only not going to make as much money for a PTSD reimbursement, but you're going to get in trouble with your network director because you're not meeting that measure. So it's those external things, you know, that really limit us and make it much more difficult.
For me, I've often resented being called the prescriber. And when I was at the VA, they said, "Oh, you're a prescriber." And I felt like as a psychiatrist, I was being defined either by the payers, because they're only wanting to pay, and I mean general payers, VA and they want to pay you for that 10 or 15 minute medication visit, and they don't want you to do more. So in psychiatry, we don't learn how to do more holistic care. You have to step out if you're wanting to take care of the whole person. And then in the training programs, that's what defines what psychiatry is. And at this moment, our Arkansas legislature is considering a bill about expanding the full practice authority of our nurse practitioners. And so it's just very much in my mind, like, why did I go to med school? And so to me, the difference is the medical school training and understanding the body and the mental health, the psychiatric care. And when I was doing my residency, I was like, when are we going to talk about mental health? All we talk about is mental illness. And so I've been very drawn to the whole health model. And so being able to go to primary care and work with a whole health model. But I love this conversation and how it's being, I want to be more than a prescriber. I'm probably not even that great of a prescriber. And when I've been in primary care, they often think that it is the little easy cases, but it's the hard cases. It's the psychotic people before they can get to their specialists or to the ER. So I love this conversation and hope that we can continue it.
Yeah, a lot of, you know, I've always resisted that term, prescribers, and people humored me. Finally, we came up with this term, providers with prescription privileges. PWPP. We're PWPPs. People call us PWIPs. I'm not sure we've gained anything. And when I'm gone in September and I'm not there, they'll probably go back to prescriber. I think, you know, they're humoring me because I've been around for a long time. But yeah, I mean, that's the term we use. And you know, and the nurse practitioner thing is interesting. I mean, that's the way the VA went. You know, allowing, you know, full practice authority for nurse practitioners. And some of it, I mean, I think it would, if every psychiatrist in the country was willing to treat OUD with buprenorphine, do you think would have needed to expand the waivers to other people? Probably not, but it's one of the things that I hear often. Well, no, I don't do that. I don't do dementia. I don't do alcoholism. I don't do that. But you know, and I think the more of these things that our profession declines to do, the more people are going to step up and say, "I'll do it." At clinical, since I work really closely with the clinical pharmacists, I'm on their executive board in the VA, and I know so many of them very well. And you know, there's a vacuum, and they have moved in, and most are probably better at picking an actual drug than I am. I may be better at deciding whether I ought to use a drug, you know, or do something else. But you know, and the day will come when you'll be able to put a drop of saliva on a little slide, put it into a machine, and it'll tell you what drug you need.
I wouldn't hold my breath.
I'll
For
try
what
not to.
that's worth. I just want to comment on two things that you're saying. One about nurse practitioners. I mean, I have some really phenomenally good nurse practitioners who I work with. However, I think you were putting your finger on something that I think is a challenge, and this may be more a reflection of many years of experience. Let's just call it being old, versus the nurse practitioners who are, for the most part, not necessarily young, but are relatively young to the field of being nurse practitioners. So they've been relatively recently trained. And I find the experience with them is similar to young residents, is that they tend to think a little bit about medications differently than I'm aware of, you know, so they're coming in with a new slant from something that was just put out. And I'm sure I did this myself 40 years ago when I was a resident, and there were the analysts in New York who I'd come in and say, well, what about this medicine? They'd look at me like, what are you talking about? So I think that there's some issue of the generational stuff, and on the positive side for nurse practitioners, as well as young residents, having some idea about what's really kind of current and what people are thinking, versus just having some larger sort of, I hope this is the case, some sense of wisdom about when it makes sense to do what, and how to sort of keep that frame, and also how to interpret and how to talk with folks, and how to actually pull in the kind of information that you need to have, how to do a good history in a way that actually touches where people are. Those are things I think that a budding workforce needs, and we need to be training people to have that broad width of vision to do that kind of work. So I'm hoping that we can get really good psychiatrists to be in primary health services, who will be the backbone at some level, on this level, for a very large cadre of people who are doing an awful lot of work at primary health services, both on the medical and psychiatric sides, to keep people whole, if that makes, make that kind of an effort.
Yep, no argument. I think nurse practitioners and physician assistants are very good with their book of algorithms, and following the script. And for a while, I had a nurse practitioner as my own provider, and she didn't use the book of algorithms. She talked to me, and there are many, just like there are many psychiatrists who don't know how to talk to a patient, or they can't relate to the patient at all in the way it should be. So we have a long way to go.
I wanted to pick up on that point about perspective and experience. The psychiatrist tending to be the more seasoned professional on the team, and tie it back in with your original question, Andy, about who needs us, or why does anyone need a psychiatrist? For one thing, in terms of being a prescriber, I like to tell people I spend most of my day talking people out of taking so many drugs. So every day I recognize so much polypharmacy going on. People are taking a different psychotropic medicine for every symptom they have. We're letting lists of symptoms drive our prescribing behavior. And so I very much try to, as Ken, you suggested, take that overview and help my patients understand that, very frequently less is more in terms of medications. And so I'm usually spending more time to get people to take less rather than more, and attend to those other aspects of their lives that are so important, including all the whole health stuff that's already been discussed. But just kind of going back to your original question, and with the OUD example, that's a great one. my value on the women's health team when I was doing that was usually being the person who could say no to the patient, especially in the midst of the opioid epidemic, and and just kind of helping them manage those really toxic and difficult requests that they would often get, especially regarding opioids and controlled substances. And so that definitely a psychiatrist is very well trained, and and goes back to my point about confidence. Like we have the confidence to say no, this is not happening, and this is why, and we're able to document it effectively.
Great points.
I think one of the problems is, it really so much comes down to, in my mind, the structure of our healthcare system and how people get paid. So as a psychiatrist, if I really value the whole person, want to spend time, or I need to spend additional time with the patient, well, I can have that if I'm totally refusing Medicare, Medicaid, and even refusing insurance companies. And so there's a lot of perverse incentives from the perspective of all patients. There's a lot of perverse incentives so that many practitioners, psychiatrists, child psychiatrists, et cetera, don't want to go that route into other care models because they can control what they have. And I'm thinking, it's just training a psychiatrist of how to be a wonderful collaborator and consultant in integrated care. Very few training programs train psychiatrists to do it that way. They, now you get places like the University of Washington and some other places but so much of it is kind of set up. It's a setup to go out and put out your shingle and then structure your practice as a small business owner the way you want to. But it totally ignores population health. And so, you think about all the problems. And then the other side of the occasion, and Andy and Patty know this, it's not like integrated care works great in the VA and all primary care providers line up and say, we love this. There's a lot of resistance among internists who say, I don't want to go there. That's not my job. And so it's a real multi-headed beast in thinking about all the areas that kind of make it difficult. And some of the folks on this call are exceptions to the rule, but the rule is everyone who's not on this call.
Yeah, and it's great. Preaching to the choir is good. And there's one PCP who taught me a lot years ago when I was called to his VA to do an intervention because they didn't want to do what we wanted them to do. He said, it used to be I identified a problem, I just sent off a consult and I was done with it. Now you want me to collaborate. That takes up my time. Many see it that way. So the trick is to make collaboration and working as a team around what's going to be helpful to the patient fun, enjoyable, and let people see the results of their patients for those kind of rewards. Not everybody's going to respond to that kind of thing. But many will. And I resisted telling that PCP, wait a minute, it's your responsibility if that consult gets lost. You're not done with them. But that is the attitude of many in primary care. I think that was, that family practice has done a lot to change that over the last 30 years, but it's still there to some extent.
Hey, I know that we're almost out of time here, but I wanted to reiterate that I agree about everything that everyone has said today in terms of the whole person health and wellness and adding psychiatrists into the primary care location and sort of expanding that role quite a bit rather than putting them in this box of doing only these certain things. But I'm facing, especially in North Carolina, I can't speak for anywhere else, but I'm facing an issue of being stuck in the parameters of what the system gives me. So if we're to accept insurance, then we have to bill these certain billing codes and these certain things, and our psychiatrists are not able to get paid for this non-billable collaboration and integration with other providers. And so I'm trying to figure out a way to, obviously as one person, I can't change the entire system, but I'm trying to figure out a way to make this system work so that we don't go out of business by trying to help people in a health way. So I think that was what my main question was, is how do I play the system in a way that I can get this whole health approach in a primary care setting with no external funding other than what we can bill.
You know, Blue Cross Blue Shield of North Carolina is pretty innovative. So you might have a, you know, an en route there to work with them. You know, one thing I love about my current is we're Medicare Advantage driven, so we get lots of upfront capitated payments for our patients, and the payments kind of based on HCCs and risk adjustment factors and all these kind of, you know, diagnostic things, and it's wonderful because it gives you total freedom to really build the collaborative care model. Or, you know, and during COVID we were delivering food to people, and, you know, because, you know, you're trying to prevent hospitalizations, which is kind of one of the big metrics that they certainly follow. But yeah, I'm with Peter. It's like the funding is so important, and I think we need to be training advocates in psychiatry residencies as well.
Yeah, and developing potential programs that you can try to sell to the insurers, as you know, as you're saying. You know, all the insurances are looking for an angle. You know, there's a lot of people out there, a lot of companies, and to come up with here's what we're going to do. Here's the outcomes we're going to show. You know, and let's do a pilot for a couple of years. You know, we just need fundamental reform of how we pay for healthcare, who pays for healthcare. We have a long way to go. I'd hoped it would be solved by now. But it's
I'll just add that, you know, the other way to approach it is go work in a primary health service that's an FQHC, because all these things don't cause as much trouble. And I think the future is very clearly in the lines of the FQHC as a backbone of an evolving primary health service in the United States.
I hope so.
Well, we have to decide that government is good first. That may be a long. We're counting on North Carolina and maybe even someday Arkansas to join us in that.
Tough sell.
Well, this is outstanding. Everything that I hoped, and I would like to say, okay, now for hour 2, because we're just getting going. But you know, we do need some nuts and bolts, and as someone pointed out, we need more info in this group about how to bill and how to keep a business going. But also we need this philosophical underpinning to our practice and how we can make changes for individual patients, but also for our systems. So that's part of what's keeping me going, to have groups like this and to bring together people that are in the field doing it, and then people that have been in the field for a while. So appreciate everyone being on, and I will share the recording and the chats, and we hope to continue having some meetings like this. We have not organized a specific day or time, and we're working toward that. So thanks so much, Andy, and for each person that contributed today. But thank you. Hope y'all have a good rest of your day.
Thanks for the opportunity.
Take care.
Good to meet you all.
Guys, thank you all.
Bye-bye.
Bye-bye.